Welcome back to Search Ahead. We want to contribute to the Breast Cancer Awareness Month, bringing some of our conversations to reflect on the initiatives that some people are having around the world to fight this disease. Today, we're going to be talking to Dr. Lily Gutnik. She is a medical doctor who graduated in 2011 at the Medical School for International Health in a joint program between Ben Gurion and Columbia University. She just finished her General Surgery Residency at the University of Utah, and currently she is a Breast Surgical Oncology Fellow at the University of Duke University in North Carolina. Dr. Gutnik, thank you very much for being here, and thanks for finding time for this conversation.
I was very flattered to be invited to participate.
What makes breast cancer the most common of the female cancer worldwide? And does the situation differ when we look specifically of sub-Saharan Africa?
Yeah, no, absolutely. So breast cancer is the most common female cancer worldwide. It's about a quarter of all female cancers in the world, like worldwide, taking all the settings, high income, low income. And there's definitely this very well documented trend that it is on the rise in low resource settings in developing countries and low middle income countries. When you think about Africa specifically, it is the leading cause of cancer among women in 30 out of 54 countries. And this is all just taken from most recent Global Can 2018 data. So we know for sure it's on the rise in sub-Saharan Africa. No one's really been able to pinpoint exactly what the underlying etiology of that is. It's for sure likely something very multifactorial. But I think it is really important to be mindful that this is a global problem. It affects women everywhere. Most of it is, I would say, non-modifiable factors. And it's important for especially countries in sub-Saharan Africa and other low resource settings to be mindful of this trend so they can help guide policy and resource allocation.
I would like to talk now about Malawi. It's a country that you definitely are very familiar with. You took some break during your residency to conduct some research in the country. And many of the breast cancer patients, they are diagnosed with large tumors more than a year after they felt the first symptoms. Why is this?
So that's a great question. And I think really there's three categories of answers. And there's basically those categories are there's patient factors, there's provider factors, and health system factors. And so, kind of taking about some examples of them in each of those categories. So in the patient level, we know that there's a huge just lack of knowledge and awareness. So one of my colleagues who was doing research in Malawi before I came, and we overlapped a little bit also at UNC Project Malawi, did a survey of just kind of the Lilongwe region and found that less than 50% of women really had any true factual knowledge about breast cancer. There's a lot of cultural issues, stigma, taboo, myths. Like I remember even just from the work I did, there was like this definitely very widely held belief, even among women that were a little bit more educated, that putting a cell phone in the bra causes breast cancer, which we know is not true. And for sure, the other thing is too, because unfortunately, because most women do present late and there's less options as well as just less treatment availability of just certain types of treatment modalities in Malawi, a lot of women who do get diagnosed with breast cancer ultimately have to have a mastectomy. And unfortunately, there's a lot of social issues surrounding that. There's definitely populations of women whose husbands divorced them after they had mastectomy, whose families ostracized them. And then just this widely held belief of like, oh, you have breast cancer, you're going to die. One of my actually trained lay women who's a breast cancer survivor herself, and just hearing her personal experience was amazing. And she came, and she was definitely from a more middle to upper middle class woman, had some education. Her husband had a business and had several children. Most of the children were actually in South Africa, doing work or studying them. So definitely a little bit more than your average, a little bit more educated and affluent than your average woman. And even in her family, when she got the diagnosis, her husband's family told her husband that he should leave her because she's going to die. He fortunately chose not to, and chose to, use the resources that they had, since, they had a little bit more, and they went to South Africa for treatment. She did ended up getting a mastectomy and other treatment, and has done well and has been a survivor for many, many years now. But even just within her own family dynamic, especially between her husband and his family, there was this tension, and they weren't supporting him, they weren't supporting her in his decision to go to South Africa and pursue treatment. They thought it was just all a waste of money because she's just going to die, so why are you going to waste your money? I think the provider factors, to me, was something I found very interesting and not as well documented in the literature, although there's definitely an upward trend in that too. But really, clinicians are just not aware of breast health. So a lot of times a woman will notice a breast abnormality, especially if you're in the more rural area or the district level, district facility level, and they will notice, for example, a lump or a little bit of a lump with some redness. And they will go in a pretty timely manner, within days or weeks of when they notice this, to the provider, and the provider just brushes it off and sends them home with pain medicine, sends them home with antibiotics. They come back, it's not going away. They'll try a different pain medicine or a different antibiotic, or just ignore her. And then, and then 9 months later, she comes back with this huge mass that's spread to the lymph nodes, possibly even starting to fungate. At that point, they're like, well, you need to go to the central hospital. There's nothing you can do here. And then, of course, the third bucket is the health system factor. So even when you get the patient who notices a symptom right away, and even when she goes to her local provider, at the district level, who has the knowledge and education and is like, this is concerning, we should get a biopsy of it. Well, getting a biopsy of it could be really difficult. Oftentimes, any sort of imaging or diagnostics are available only in the tertiary hospitals, which could be 100 kilometers away. And so do they have the money and the time to go there? Plus waiting, plus, then getting, a lot of times they'll have to then pay out of pocket. Then is there resource availability, even if they manage to get themselves to the tertiary center, supplies to do biopsies aren't always available. People that can do the biopsies aren't always available. Then sometimes, even if they do get, transporting the sample to the path lab is a whole other adventure in itself. And then getting the results from there back to the patient. I mean, it's just a very, in certain settings, it's just a very cumbersome and not streamlined and difficult process to go through. So I think there's issues in all of these levels, and I'm sure there's interaction and interplay between all of them as well.
You are part of a project that was conducted in Lilongwe, where lay women were trained on clinical breast exam screening. Could you just tell us a little bit more about the project? Where did you get that idea from, and the conclusions that you got from it, please?
Yeah, so actually, I was inspired by a study that was published in the Lancet Oncology in 2013 that was done in Sudan. And it was a big cluster randomized trial of basically training lay women to do screening clinical breast exams in a door-to-door kind of fashion in the intervention villages versus the control villages, which was just kind of status quo. There was no intervention. Women would just seek breast care as they normally do. And basically, they found through this intervention that they were able to find significantly more cancers and earlier stage cancers in the intervention group than in the control group, which were only 4 women were diagnosed ultimately with metastatic stage 4 disease, and then they sought care on their own. So that's knowing that was a study that I had read, and I was just like, wow, this is amazing, incredible. And again, I was equally just excited and intrigued and being like, this is such a good opportunity. And so that was something that we were interested in doing. Malawi at that time, my Malawian colleagues and collaborators definitely had an interest in breast cancer. And as we just talked about, anecdotally, we just knew this trend that most women present with large tumors with more advanced stages. And so there was an interest on what can be done about this. We identified and trained 4 laywomen. As I mentioned earlier, one of them was a survivor, which I thought was a really great addition to the team, and just again, really learning her perspective and her own personal experience, I think really had a positive influence on the other laywomen and on all, just the study population in general as well. And then we ultimately screened 1,000 women. And the way our study worked was we used a more urban integrative design. So we were based in Kamuzu Central Hospital, which is a big tertiary hospital in Malawi, the capital. And we were in several already established clinics. And what we did is while patients, both men and women, anyone were waiting in the waiting room, we developed this whole flip chart breast cancer education talk. And that was just to educate the general public, anyone who was in the waiting room, just about breast cancer, answer any questions. And then also the main purpose of that was just a general public health measure. But for the general population, no one had ever really even heard of screening or knew about it. So that was the other thing. Before we wanted to approach them to see if they wanted to participate in the study and get screened, they needed to understand what breast cancer was, what screening was. We found that these lay women can easily be trained to do this work, that we had an 88% concordance between physician exam and laywoman exam, so meaning they could do this clinical breast exam just as well as physicians can. In terms of our education, we gave a total of 175 breast cancer talks attended by almost 4,300 people, and that's both men and women. And that was just an amazing experience in itself. So many people came up to our laywomen who were giving the talk afterwards asking questions. We even had some men come up and saying, oh, can my wife get screened? Can my sister get screened? It was really powerful and just and all of this was done in the local language by our Malawian laywomen, which I think is important. But it was really just powerful, opportunity to dispel some of those myths and really just raise factual awareness. Women really wanted to bring this to the community. That was the most common thing they said especially when we were asking them, how would you like to see a screening program in the future? And they said, instead of what we were trying to do is this health integrated approach, trying to make it a little bit easier on the woman, because if you're already coming to the doctor for XYZ, while you're there, here you can get a 10-minute breast exam. But they were actually no, come out to the community so more women can get screened. And it was very, very positive feedback. So we were very excited about that.
And do you think this project could work in rural areas?
I definitely think it could work. So one of the other things I'm involved in Malawi is a grassroots breast cancer advocacy group called Think Pink Malawi. And it was started by Blandina Kandwawe, who was former Miss Malawi back in the early to mid 2000s, I believe. And she herself is kind of Malawi's most famous breast cancer survivor because she had breast cancer. And even her journey from when she's being a wealthier, well-known woman in the country, from the time she noticed the symptom to when she got diagnosed took 15 months. So again, saying, and this is a woman with knowledge and education and resources and connections. And again, very similar, a lot of the things were at the provider level, she was told she was too young, that it's just a lump, that it's just a mass. She was pregnant actually at the time when she first noticed the mass. So they were told oh, it's just, this happens during pregnancy, it'll go away. And then it never went away. So, a lot of her personal experiences, she ended up getting all her care in India. Again, she was a different socioeconomic status. So she was able to do that. But then during her treatment in India, she actually started this blog about her experience. And that's when she really realized, how fortunate she was to be able to then finally get the diagnosis and get treated in a different country that had more resources available, but just how majority of the population would never have that opportunity. So she's been sort of on this quest for just public awareness and education, and just also the taboo and the cultural stigma associated with it. And then she's actually also been writing a column in the Nyasa Times, one of the big local publications, sort of a kind of a cancer column to help, again, dispel the taboos. In 2014, we did the first ever breast cancer walk from Parliament to the Lilongwe Wildlife Center. And then there was like all sorts of other activities and a car boot sale and a bake sale, and various speakers and survivors and members of Parliament participated, and various other UN agencies and everything, to just really a big October awareness event. And that was in 2014. And since then, it's an annual initiative that we do. And over the last few years, we actually started to add like a screening tent. And we've done both. We've recruited some nurses to do VIA screening for cervical cancer, and then nurses as well as some trained laywomen to do screening clinical breast exams. And then a couple years ago, and it was again mainly focused in the urban area, but a couple years ago, we actually went out to one of the rural districts outside Lilongwe, and we had 700 women show up. So there is definitely a need and an interest.
Having heard how important the participation of lay women was for this project, and especially in improving the breast cancer awareness and diagnosis, do you think that the global health community needs to improve the creative aspect of their fight against breast cancer?
I definitely think so. I think there's definitely been, a lot of literature in global health about this concept of task shifting and task sharing. We've seen that across, HIV and even surgery and obstetrics and maternal care. And that's why, the rise of the community health worker. So I think there is some precedent to that. And I think that those groups should continue to be leveraged and used. But I think also, as we've learned from my study and the study in Sudan, that there's other groups of people that can be activated and become active in this journey, with breast cancer. If you want to do something that's sustainable and truly impactful, you can't wait for the next big idea or the perfect point of care diagnostic test to land in rural Malawi. You have to start with what you have. And is what you have, a lot of times is just motivated community members that can be activated, that can be leveraged, that can be taught, that can be educated, that can contribute. So I think a lot of times there's this focus on the $1 million idea that's gonna cure cancer, but realistically, you're just wasting precious time, in my opinion. And not to discourage working from that, and I think that's great. But at the same time, I think it is really important to just be very honest with what's available right now and what can you do with what you have to make the most impact.
Thank you very much for this passionate way of explaining your work. I wish you all the best, and really thanks for having found the time for being here with us today.
Happy to participate, and happy to collaborate at any time in the future.
And for you all, thank you very much for having watched this video. You can find all conversations from past months now on our website. Don't forget to follow us on Twitter, YouTube, Facebook, Instagram, you name it. Take care and keep yourselves safe.